Hello and welcome to this Facebook Live seminar. My name is Joy Tickle. I'm a tissue viability specialist from Shropshire. Today we'll be focusing on biofilms and wound infection with real-life patient experience. The seminar is supported by Essity, formerly BSM Medical, and contact information is available at the end of this presentation. We'll now move on to the presentation entitled Working Together to Manage Biofilms and Wound Infection. Let's look at this evening's learning objectives. I want to address with you the NHS long-term plan. You might say, how does that become involved with wound infection? But there are significant implications around that for infection management. To introduce the National Wound Care Strategy Programme, a really exciting programme that we can all be involved in, and address how we can do our bit to support it. What wound infection is and how it can develop. Now, I know we've addressed this in former Facebook Live presentations, but again, it's really important when we're talking about biofilm management and, of course, biofilms and their impact on wound infection and healing. And finally, looking at that holistic management of the patient with a wound infection and implementing biofilm-based wound care with personal experience. So the NHS long-term plan, Theresa May last year, marked our 70th anniversary of the NHS with a pledge of £20 billion of funding over the next 10 years. But it caused a national debate which was really important, and three big truths came out of that national debate. One, which is most importantly to me, there is pride in our health service and our NHS. There is still pride there, and most importantly, that's true. But there are concerns about funding, about increased inequalities and pressures from an ever-growing and ageing population, and this will only increase. So it did recognise a big truth there. And finally also addressed that there are possibilities though, with investment, with restructure, about optimising care for patients, advanced care, advanced medical and nursing care to enforce better outcomes or implement better outcomes, should I say. So looking ahead to the next 10 years, okay, the NHS 80th birthday, the long-term plan takes those realities forward and it uses them as a starting point and sets out a new service model for the 21st century. And what we're looking at is more involvement with the patients, addressing those health inequalities, encouraging self-care, encouraging taking ownership and responsibility, preventing ill health as opposed to curing ill health, looking at things like smoking cessation, obesity, alcohol, and most importantly, antimicrobial resistance, because it is still a massive challenge for the NHS and for patients. Their challenges also and their progress is to look at further progress on quality of care, to listen to staff, to look at resources, to give the staff the support, the time, the resources to care. Certainly enabling the use of digital IT systems that can again mean quicker access to healthcare, involve the patient in their healthcare and allow them to take ownership of their healthcare. All which I think is very positive moving forward in the NHS. One of those areas was the antimicrobial resistance, that government 5-year plan. We know between 2013 and 2017, there was a reduction by about 13.2% in the number of antibiotics prescribed or dispensed, but it's not enough. We still need to get that significantly reduced because we need to reduce the need for unintentional exposure to antibiotics. The resistance, antibiotics resistance is a global problem, but very much nationally for us. We need to support the development for new antimicrobial agents, and I very much welcome the NHS long-term plan to look into that and to address that with more research and evidence. And certainly continue to support system-wide involvement, improvement with infection prevention, controlling practice and ensuring antimicrobial stewardship. And that's what we can all sign up to and be actively involved in. And what was really exciting for me, particularly working in wound care, was alongside with this last year was the introduction of the National Wound Care Strategy Programme. The director, Dr. Una Adley, is very much passionate about having a national wound care strategy in England. There are various work streams. I don't have time tonight to tell you all about them, but very much focusing about that really good national consensus and support of wound management for everybody that's involved in wound care, and most importantly, it involves the patient and the carers. So they have work streams such as pressure ulcer prevention, leg ulcers, surgical wounds, and I feel very passionate about the education and information. So ensuring our workforce and all people involved in wound care, including patients, are educated and informed. And there's various work streams. And what we can do is get involved. You know, they are very keen to hear the views of anybody involved in wound care, and patients and carers most importantly. So you can see there is an email address on there. I'm not going to read that out to you, but very much get involved, register your interest, encourage your patients, your carers to register their interest. We need to work together to ensure that this national wound care strategy is a success. Or sign up to one of the stakeholder forums. Again, the link is there. Have your say, get involved. So let's begin. The main bulk of tonight's presentation is around wound infection, but I felt we needed to set the scene about where we are in the UK in 2019, where wound infection is concerned, and how we're going to move forward. We do know, and we'll always know, that all wounds, whether they're acute or chronic wounds, are contaminated with microorganisms, whether that be from the environment or the patients. I'll give you some examples. Dressings. If the dressing wear time is not suffice for the amount of exudate, then that exudate may sit within the dressing. That exudate then may cause an increase in microorganisms or microburden and increase the risk of infections. If the dressing is not suitable for the amount of exudate or the type of tissue within the wound bed, again, that may lead to an increased risk of infection. Patients' own bodily fluids could contribute to contaminating and causing an increase in microorganisms, particularly in a wound locality where there may be some issues with contamination from urine or faeces. The hands of a patient, of a care provider, of ourselves. You know, so protecting the patient, protecting yourselves. It's very easily we can introduce microorganisms and cause them to become more virulent if our infection control is not effective. We are all aware of the impact of wound infection on organisations. We talked about this on previous presentations. It's a massive cost to healthcare organisations, certainly increased cost in clinicians' time to care for a patient with a wound infection. But any of you that know me know that my passion is it's the cost and the impact to the patient themselves. You can see on your screens the image of this patient with an infected not only toe, but this infection is spreading along the foot. We can almost imagine that pain, but if you imagine that pain to be extreme, then double it, because it will cause significant pain and suffering. Now, I am aware that in some patients with neuropathy or lack of sensation, they may not have those classic signs of pain and suffering. But again, don't let that take you away from the fact that there may be infection spreading. The increased risk of sepsis. We're all aware of the national agenda around sepsis, but significantly, patients with wound infections are at a high risk of sepsis. Increased exudate and malodor is consequently a consequence of wound infection. But how do the patients manage with that? When a wound is malodorous and smelling, when it's exuding that they can't leave their home, or even if they are housebound, they're embarrassed to take visitors into their home or family members. They become socially isolated, they become depressed and distressed. And we all visualise, I think, wound care with the elderly population, but it's not. It's affecting all age ranges. So, you know, please don't just think around the elderly. Anybody who's at risk, young and old, can develop a wound infection. And it's going to significantly delay the wound healing or cause the wound to deteriorate more significantly. So extend the wound surface itself and extend along other tissue. We're aware of wound infection continuums such as this one, and as we said, all wounds contain microorganisms, so they may just be colonised within a wound bed, and they will be, but they're not causing a harm to the host or to the patient, as we would call it. But you still need to be observant of that, because it's when those microorganisms increase in volume and virulence that they may start to impact on the wound healing. They then may equally, as they increase, as you can see along this continuum, impact on promoting wound infection and, if untreated, systemic wound infection. And we then do need to treat those infections with antimicrobial agents and possibly antibiotic therapy. So again, using a wound infection continuum within your practice will assist you in helping to address those risks. If wound infections are untreated, there's lots of complications, too many for me to mention tonight. But certainly cellulitis is a common one associated with untreated wound infection, and we know how significantly painful that can be. Commonly, it can be confused with inflammation, but vice versa. Chronic inflammation of a limb is very frequently diagnosed as cellulitis. So diagnosis of wounds and wound infection is so important. It needs to be accurate in order to prevent mistreatment or inaccurate treatment of that wound infection. If the infection is involved in or spreads to the bone or is involving the bony tissue, of course, then there's the risk of osteomyelitis. That is a lot more difficult to treat. It is treatable, but you need to work as a multidisciplinary team in order to do so. But sometimes that osteomyelitis may lead to amputation of bone or digits, etc. So bearing in mind the impact then onto the patient and the patient's activity, living and quality of life. And finally, the septicemia, the death that we've already discussed. Again, patients can die from wound infections. So we begin with that holistic assessment of wound infection, and I know we use that word quite a lot, don't we, holistic, but it really is important that we're not just addressing the wound itself, we're holistically assessing the patient, and I will reiterate the patient's environment as well when we're dealing with wound infection, the wound itself and other factors. So we really need, if we feel that there's infection, microorganisms multiplying, we need to look at that reaction between the patient and the microorganisms and try and allow the patient themselves to optimise their response. For example, by that I mean, if we can optimise a patient's health, they'll have a more positive ability to fight those microorganisms multiplying or to fight infection. So, for instance, a patient who's diabetic, who's a higher risk of infection, if we can maintain really good glycemic control, we can assist them and the patient's body to help fight that infection. So it is optimising the patient's response. We need to reduce the number or the virulence of those microorganisms, and we'll go on to talk about that. And certainly then, on top of that, optimise the wound healing environment itself. So really ensuring that the wound bed environment is optimal to encourage the wound healing continuum. But again, not forgetting though, you're implementing your local infection control policies and procedures. Diagnosing wound infection, I think we still routinely too much take wound swabs. I'm being honest there. I see that in practice myself. And a wound swab only identifies the microorganisms. It does identify if it's sensitive to any certain types of antibiotics. But it doesn't tell the microbiologist whether that patient should be treated for wound infection. It's the healthcare professionals that need to make that assessment and look at the risk factors and signs and symptoms of wound infection before even thinking about taking wound swabs. So diagnosis is based on the assessment of the person. So are they feeling unwell? Are they pyrexial? Are they generally feeling lethargic? Are they not eating as well as they should be? And they've got a loss of appetite. Look at the wound itself. Is the wound bed itself telling you that the signs of infection? Is there any malodor? Is there increasing erythema or redness spreading around the peri-wound tissue? Is the wound bed tissue sloughy? Is there some necrotic tissue? Again, that is the assessment of looking at any signs. And as I've just said, looking at any systemic inflammatory response, which is really important in addressing and preventing sepsis. So we're looking at all of those factors before we even consider about whether we're going to do any diagnostic tests. What I will say regarding wound swabs, because I know it's always a question that gets asked, is I always ask myself, when I'm looking at a patient with a chronic wound or an acute wound, and I'm looking for any signs and symptoms, and I might think there's some localised infection there, I ask the question before I take a wound swab. If the wound swab indicates that there are microorganisms present and they're sensitive to a particular antibiotic, which they probably will do I treat with antibiotics? If the answer is no, because I'm going to use a topical antimicrobial, then you don't need to take a wound swab. To me, it's only if the patient's becoming systemically unwell or you're seeing evidence of any spreading infection or deterioration of the wound significantly. Management of wound infection, as I've just said, it's that prompt diagnosis, it's having that diagnosis, and that again comes from clinical signs and symptoms. But not only as clinicians, all of us involved in wound care should be aware of the signs and symptoms of infection. And tonight I can't go through all of those with you, but you can, go back to our previous presentations that talk about that. But our patients and our carers should be taught of how to recognise the signs and symptoms of wound infection. You may only see your patient twice a week or 3 times a week. You may not see the same patient every week, and I understand that. I work in clinical practice. So teaching our patients, taking ownership of looking for those signs and symptoms of infection, because they can alert you very quickly if anything changes in their wounds, and particularly if pain increases or changes in any way. So it's really important we involve the family, the carers, and obviously the individual themselves. Any treatment plan for infection, it's got to be clear and decisive, so that there's that continuity of care, continuity of treatment, so that we can check and reassess whether the treatment is, whether the patient's wound is responding. If we change treatment plans too frequently whilst the wound is infected, then we don't know if the microorganisms are being responsive to the treatment we're using. As I've just detailed, the patient's immune response, let's try and optimise that, and not just through comorbidities, simple factors such as smoking, alcohol intake, nutrition, hydration, rest and sleep, all factors that will help us to fight infection and to treat infection. And many times I certainly work as an MDT team approach when a patient's got a wound infection that's not responding. Talk to your microbiologist, discuss with them, the signs and symptoms, talk with the medical profession, talk with your colleagues, and talk with the patient. We really need to work together. But let's not forget there may be other sites of infection, so please be assessing for those as well. For example, urinary tract infections, catheter site infections. Let's establish that there's no other infections present elsewhere. Management continued of that wound infection, to me, for the patient, is symptom relief. It really is important. You can imagine if that was your toe, it may seem a very small wound to you, and certainly if you work in tissue viability, you might say that's a very small wound, but significantly painful wound. Looking at clinical signs and symptoms for the patient, any factors there, and support them, because the advice we'll be giving, basically if they're in pain and we're asking them to stop smoking, will they stop smoking? Probably they will smoke more. So we need to ensure we have a really good pain assessment and manage that pain as an MDT team with the patient themselves. If we're asking them to rest, enable their body to fight the infection, again, if they're in pain or uncomfortable or it's reducing mobility, then, again, they'll be reluctant to do so. Let's look at any local factors that might be present. So devitalised tissue, as you can see here, there is slough, there's eschar, there's devitalised tissue. We need to remove that. The microorganisms love that environment. They will certainly multiply in that environment, and we need to reduce those local factors that are going to contribute to wound infection. This is excessive exudate, excessive exudate, as I've just said, for a wound bed. We need to manage that exudate. We want a moist wound environment, but we do not want high levels of exudate across a wound bed or peri-wound skin, which will only increase the micro burden to that area. And again, even addressing the locality of the wound, for instance, on this patient, the locality is on the foot, it's on the toe. So think about offloading pressure there. It may not be linked to a pressure ulcer, but we certainly need to offload the pressure to allow that wound to try the tissues and cells to multiply and migrate across the wounds. And again, if edemas are present, treating the underlying problem. We've talked about wound bed preparation. I love the time and wound bed preparation acronym. It addresses the barriers to wound healing. The principles of wound bed preparation, as we can see, time, tissue, infection or inflammation, moisture, excessive moisture, and the edge of the wound. But what we're concentrating particularly with wound infection and biofilms tonight is the tissue and the infection side. So we really need robust therapeutic wound cleansing, and we'll go into more detail. We need to disrupt any biofilms, and I'm going to talk to you about what biofilms are briefly in a minute. And we need to remove that necrotic, non-viable tissues through really thorough wound debridement. So we're cleansing and we're debriding. And reduce the risk of reinfection, because all of that hard work that you're undertaking and your patients are undertaking, we've got to continue that and reduce the risk of reinfection or further infection as well. So looking at your techniques. Now in the community, it's very difficult in some environments to ensure an aseptic technique as opposed to in a hospital setting. What I will say in my clinical experience is we try and be as clean, aseptic as possible with the environment we're working within. And again, addressing your own local wound infection protocol. So antimicrobial agents then, we will then address, so we're removing the devitalised tissue, we're addressing any increased levels of microorganisms, so we're cleansing and debriding, and I'll talk to you about some methods of that in some of the case studies. But once we've done that, we've got to reduce that microorganisms or destroy or inhibit them. So we normally go along the route of antimicrobial agents, don't we? Topical antimicrobial agents are compounds that can normally contain within a dressing. The most that you and I will use are in a dressing. So there's a majority of agents. We can talk about lots of antimicrobials, but they're generally described as broad spectrum, which means they have the ability to either kill or just control the growth of the organisms commonly found with an open wound bed. Before we use antimicrobial agents, we must really address the holistic assessment of the wound itself so that you choose the appropriate antimicrobial, not just for the wound bed, for the patient themselves. Know how the antimicrobial works, know what properties are within that antimicrobial. Okay, check that it's suitable for the patient age, check that it's safe to use, and check that, of course, it's not going to release any toxins to the patient itself. So, when you're selecting an antimicrobial, I know we're guided by formularies, but please, as clinicians, as healthcare professionals, know how that antimicrobial works, know what the properties are within it. What we normally recommend when using the antimicrobial based on your wound assessment is a 2-week challenge. And what I mean by that is we use a topical antiseptic for 2 weeks, and that should be sufficient time for allow that agent to see if it exert a beneficial activity. If there is no beneficial activity after 2 weeks, then we normally say change the antimicrobial itself or the antiseptic. So change the type to a different type. If the wound in 2 weeks is progressing well, but there's still those subtle signs of local infection or that you're still concerned about, it is justified to continue for a further 2 weeks with that antimicrobial. So again, having that really clear and transparent wound infection management plan. Antibiotic therapies, again, alone should not be used routinely for the promotion of wound healing. I've already emphasised that. And they should only be reserved for wound infections confirmed by clinical signs and symptoms and/or confirmation by the microbiology inquiry, but not just by that alone, as I've stressed, not just by the wound swab alone. It's by the clinical signs and symptoms that the patient may present or the wound itself. So if we are using that antibiotic therapy, we've really got to use that in combination with that effective wound bed preparation, that effective prudent wound management strategy. So the debridement, cleansing, therapeutic cleansing, use of an antimicrobial as well. So using it in combination. But when you're thinking about antibiotic therapy, just understand, can the antibiotics reach the source of or site of infection? Discuss that with your MDT team, discuss that with the microbiologist, etc. Because it has to be able to get to the site of infection in order to be effective. So as I've said, and I have said quite a lot this evening, systemic antibiotics reserved only when the degree of infection is unable to be controlled with local intervention alone. And don't forget that debridement. I frequently get asked, how often do you reassess a wound, Joy? I would say informally, you reassess a wound every time you see the patient, every time you see the wound. You are informally reassessing not only the wound, you're reassessing your patient for any changes in signs and symptoms. For example, I may ask my patient, has the pain decreased now? Or what is your pain like? Because they may not have had any pain and suddenly they're saying to me, there is pain now present. Okay, but if I'm reassessing when I've implemented an effective wound infection plan, then these are the sorts of things I would be looking for. So has the patient's pain decreased? Has the exudate level decreased? Because as the bacterial burden decreases, the exudate level or volume should start to lessen also. As if there was malodour, is that malodour now resolving? That's normally a good indicator that, again, we are destroying or inhibiting that bacteria present. If there was any redness or edema, is that increasing? Is the non-viable tissue now reducing? So, for instance, when you carry out your wound assessment, do you use percentages to look at your non-viable tissue or your tissue type? So, for instance, the wound you've just seen, we would describe as 100% devitalised tissue. If I then see the wound a week later and I can now see, say, even if it's only 10% granulation tissue and 90% non-viable tissue, then I know it is improving. So again, using really robust assessment tools, just simple tools that can help you to look at that reassessment. And certainly is the wound reducing in size or depth, and we are aware that we should be measuring and sizing our wounds frequently. And again, is there limited or no improvement? Because if there's no improvement, we've got to rethink the whole assessment, reassess the individual, reassess the environment, the wound and everything else, and look if there are any underlying risk factors that we are not addressing. That takes us on to biofilms, because I think that, particularly in chronic wounds, they sit very, very closely together. Now, I only have a really limited period of time to talk to you about biofilms, so I would recommend you go on and you look at other modules around biofilms and infection following on from this presentation. We know biofilms, and I like the point about fact or fiction, for sometimes have been implicated in a wide range of diseases, and commonly from my nursing career it's very common in chronic tonsillitis, chronic sinus problems, UTIs, and very frequently dental decay. And that's where normally biofilms are only visible, which is on the teeth. It's only relatively recently that biofilms in wounds has been recognised as being potentially pathogenic. And despite significant advances in emerging science and research, we've still not got that full understanding of wound biofilms in a clinical context. But what I will say, we've got a better understanding, and there's lots of good work going on and has gone on into biofilms and its impact on wounds. It's thought that nearly all chronic wounds will contain a biofilm, so 78.2% with some work done by Malone in 2017, and 6 out of the 9 studies she looked at, over 6 out of the 9, 100% had biofilms in their chronic wounds. What is a biofilm then? Biofilms, they're a community of those microorganisms. So we've got microorganisms that are sitting in a community. And normally microorganisms or bacteria is planktonic. It's free floating and it will attach itself, if we're talking wounds, to the wound surface or normally the collagen. And it'll attach there, and normally our own body response, our own immune response, our macrophages and neutrophils will attack that bacteria and reduce the number of bacteria present, and normally that's fine, we can fight that bacteria and it's harmless to us. However, in chronic wounds, what is formed is the free-floating bacteria, the planktonic bacteria, attaches and forms a little colony. And it attaches very quickly in about 2 hours. When that happens, what is equally as happening is the colonies then, because of the chronicity of the wound, we start to get a biofilm forming. And what that is, it's the colony of microorganisms, but they've become encased now. So they're not free floating, they're attached, and they've become encased in a extracellular polymeric membrane. If you just remember that as a hard casing, it's a hard shell that protects that community of bacteria and microorganisms. It's made up of protein, DNA, polysaccharides, but it really causes a very dense matrix around that colony of bacteria. So that means that our own antibodies, so I can sense that colony of bacteria and I send out my neutrophils and macrophages to attack that bacteria. It cannot penetrate that dense extracellular matrix, that wall, that casing. I then decide I'm going to use some antimicrobials to attack that microorganisms in that wound. Again, the antimicrobials or the activity of the antimicrobial cannot get to the source or the microorganisms to either inhibit or destroy it because it cannot get through the extracellular matrix. And then on top of that, we decide we're going to give some antibiotics as well. And again, the antibiotics, due to the density of this extracellular matrix, can't effectively penetrate that wall. So basically, we've got a real robust colony of bacteria that's been protected and encased within that area. As I've just said, they're protected from the patient's immune system, they're antimicrobial agents, antiseptics and antibiotics. And basically, in a simple way, because of the protective coating and also the bacteria or the activity or metabolic activity of the bacteria in a biofilm becomes inactive, or they go what we call dormant or go to sleep. That again means that the antimicrobials, antiseptics, etc. Cannot be as effective against the inactive bacteria. This is a simple diagram of 5 stages of biofilm formation. The reason I've put this up is just to show you how quickly those colonies form. How quickly after 2 to 4 hours we get that after 6 to 12 hours we start to get that extracellular matrix forming, and that casing after just 6 to 12 hours of those microorganisms forming is now become encased, and within 2 to 4 days it's a very dense, mature biofilm. If we disrupt that biofilm, and I'm going to tell you how we can do that in a minute, within 24 hours, that biofilm can start to reform. So again, it's that constant breakdown of those biofilms in chronic wounds. It needs to be consistent and regular. And hopefully that gives you some clarity. So for example, if you see a patient on a Monday, and you do a really good biofilm, implement a really good effective biofilm pathway, then normally 2-3 days later, when you next see the patient, they have already started to produce those mature biofilms. And biofilms don't necessarily lie across the whole surface of a wound. They can be in little islands or satellite points on a wound. And there can be different biofilms, so the biofilms can contain different organisms as well. So they're very clever, and they communicate by quorum sensing. So they very, very much can see a disruption in their environment. They'll communicate to each other, and then they can act against any changes in the environment also. But I would recommend you read a little bit more around biofilms. It's really interesting. So what does that mean to the patient? What does that mean to the wound? The biofilm formation causes an imbalance of those protease inhibitors. And those protease inhibitors will then go on to destroy essential proteins. So we get that imbalance, we get the proteases, and they will destroy our essential proteins we need for wound healing. Okay, so we're already delaying the wound healing. On top of that, it encourages a decrease in growth factors, a reduction in cell proliferation, so the reproduction of new cells is reduced. A reduction in the cells even migrating across a wound bed. So you can understand when patients and clinicians say, my wound has just stopped healing, it's static, it's stagnant, it's not moving on. And these are really good indicators of the impact of a biofilm on a wound. And despite, you may even say, I've used an antimicrobial for 2 weeks, but it's still not improving. The chances are it's because you're not breaking down that extracellular matrix. The antimicrobial or antiseptic you're using cannot penetrate and destroy or inhibit the bacteria. And that's normally the reason I frequently get asked why an antimicrobial isn't working. I do take it back to the wound bed preparation and breaking down that extracellular matrix. And that causes then a chronic inflammation, a really long-standing chronic inflammation in the wound bed and the tissue. Again, that's going to delay wound healing. What equally that will do is increase exudate volume. And guess what? If we have an increase in exudate volume, we're possibly going to have an increase in the microorganisms that are being reproduced. So we have to break that cycle and that impact of the biofilm formation. So how do we do that? What I want to just show you is 3 slides of chronic wounds, different chronic wounds. Yes, mostly on the lower limb, but that's, not through any other reason that they're just on the lower limb. Can you see a biofilm in that wound? Any of those wounds? Are they visible? Sometimes you do read not evidence or just case studies that talk about that shiny appearance to the wound, and I think you can see that in some of those wounds. You can say, oh well, potentially they're all chronic, so they may have a biofilm, but there's no real visible evidence of biofilms. It's very much microscopic evidence that we get on the presence of biofilms. What I will say though, there's lots of emerging good work on how we can, I say test for biofilms, but certainly be aware of if there's a biofilm in a wound, so watch this space. I think that's interesting work that's going to come out. Well, the reason I put the 3 wound pictures up for you is just remember the majority of chronic wounds will have a biofilm. There's evidence out there, there's scientific evidence that suggests that. So I would say with all of your chronic wounds, look at implementing a really effective biofilm wound care pathway, which generally is really effective wound bed preparation and the use of antimicrobials appropriately. So what we're trying to do with biofilm-based wound care is to prevent that reattachment, because you saw on the 5 stages of the biofilm, we want to prevent that attachment in the first instance, but also that reattachment. We want to interrupt the microorganisms from communicating. So we want to break that quorum sensing and prevent them from communicating and changing as well. And then on top of that, we want to prevent them from reforming. So biofilm-based wound care, it's used really, it's a term used to maximise strategies to manage those non-healing wounds and by targeting those biofilms itself. How can we do that? Very much around really good wound bed cleansing, effective wound bed debridement. Now debridement, I know some of you may be going, I don't debride wounds, because we normally associate debridement with sharp debridement, where you require the skills and training to undertake that, where we physically with instruments remove the devitalised tissue. But again, not all of us have the skills to do that. There may be lava therapy that some of you may use, but again, it's accessibility of that. There are simpler methods of wound bed debridement. We very much rely on the patient's autolytic ability, or the wound's autolytic ability, to break down that devitalised tissue, and you'll be using your wound dressings and antiseptics to do that. But we need to ensure that is ongoing, that frequent wound debridement and cleansing is there. So I will say to all of you, you all cleanse and debride wounds. It's how we do that and how we can do that enough to break up the biofilms. And then on top of that, we want to inhibit that cell reproduction. So on a very, very quick analogy, and I've used this analogy before, and I think it's the best way of saying it. This morning you all woke up and you may have seen the biofilm, but you certainly would have felt the biofilms on your teeth or your gums. So you're probably all doing that, hopefully, or maybe not, drinking your wine whilst you're watching me, but you will have felt those biofilms in your teeth, and that's why they're normally quite visible, particularly in people who don't have good hygiene within the mouth. So I will ask you, did you just get your antibacterial toothpaste or your anti-whitening toothpaste and put that onto your teeth? No, you didn't. So what did you do? You got a toothbrush and you disrupted the biofilms on your teeth. You broke down that casing so the antibacterial, antimicrobial, or the toothpaste can then attack the bacteria. This evening, that was this morning, this evening you will repeat that, and you're repeating that because, as we've just said, they are reforming. And that's how you've got to look at debriding and cleansing and the wound bed preparation for any chronic wounds. It has to be regular and consistent because of the reformation of these biofilms. So on top of that, as I've just said, we need an effective antimicrobial dressings, and we need to prevent biofilm reformation. And if necessary, alternate the topical antimicrobials if there is little response with the first one being used. If after 2 weeks it's improving, as I've said, you can continue with that if there are still signs and symptoms of wound infection. If it's not improving, reassessment, rethink. We're aware, or I'm certainly aware of, I always address what type of antimicrobials I'm using. I see children and babies through to adults. So I'm always aware of what that antimicrobial contains, its efficacy, its safety. What I want to talk to you about is the Cutimed Sorbact range, and basically it's an antimicrobial dressing that actually works on very much hydrophobic interaction. So it doesn't contain any chemicals, it doesn't contain anything that can cause toxic effects or side effects to the wound bed or the wound or the patient itself. And how it works in a moist wound environment, it attracts and binds bacteria, fungi through that hydrophobic interaction. So most common microorganisms in a wound are hydrophobic. So because of the properties of the Cutimed Sorbact, it draws the bacteria into the dressing itself and it irreversibly binds it. And so once it's bound into the dressing, it's effectively and safely reduced the microbial load when it's removed at each dressing change. And I'm just going to share some of that with you, and there is lots of evidence out there to support this. This is a lady who's 55. She's got a history, as you can see, of 10 months duration of this venous leg ulcer. She's a teacher in a secondary school and she's married with 2 children. She's experienced over the last 10 months really high levels of pain and recurrent episodes of infection. Within the 10 months she's had 5 lots of antibiotics. Again, I will ask you, do we need to treat with antibiotics? I only met, this lady was only made present to us recently. Her words, when we all set objectives, don't we, when we look at a wound, my objective is to reduce the bacterial burden, my objective may be to obviously improve the wound in size and promote it to heal. But her objective was she just wanted that wound to stop ruling her life. She wanted to stop the pain and she wanted to stop the recurrent infections, and very much didn't want to keep taking antibiotics because of the side effects she was having. And she's a very clever lady and we're all aware of antibiotic resistance. Her concern was, you know, antibiotic resistance. Had anybody discussed that with the GP or with the team that were prescribing the antibiotics? So you can see with the leg ulcer at week 1 beforehand and at week 6, This leg also, she got signs of lipodermatosclerosis. We undertook a vascular assessment. You could see the hemosiderin staining. The reason I put that on is don't just focus on the wound. Look at the underlying diagnosis. Look at the etiology, because if we don't address the underlying cause and the factors affecting that wound, then the wound will be slow to heal and just as increased risk of infection. So, for example, compression therapy. Although the lady was having compression therapy, we looked at a compression therapy that she could do herself in the wrap systems. But basically what we looked at was really good, robust biofilm pathway and good cleansing. We did effective cleansing. We also did debridement with the monofilament pads, and we introduced the Cutimed Sorbact. She was happy because she was worried about all the different types of antimicrobials she had. She was worried about the antibiotics. She was equally ecstatic because she was involved in her care from the self-care point of view. At week 6, you can see the significant reduction in size. But most importantly to the lady was after 6 weeks, the wound was healing. That gave her, psychologically a real boost. She'd had no antibiotics. Her pain was virtually not problematical apart from the odd alternate day. She could return to work. She could actually decide, that she could take her children out because she was too embarrassed with the leg itself. The final case study is a patient who had a postoperative wound infection. You can see he presented with, he's a 66-year-old gentleman who presented with a very discoloured black necrotic toe, rapidly deteriorating. He's got a history of polyarthritis nodosa. Sorry about that, I'm going a little bit dry here. And again, it's knowing the underlying patient's comorbidities that may affect their ability to fight infection or certainly increase their risk of infection. And this gentleman was on medication that did cause some problems with immunosuppression. So again, addressing all those factors. But this gentleman was independent. He worked. He wanted to resume work. He didn't want to be dependent on healthcare professionals. Of course, this just wound bed preparation alone wasn't enough for this gentleman. He was referred urgently to the vascular consultant and he underwent a toe amputation. Following the toe amputation, he had dehiscence of the wound due to infection, and of course that caused more debilitation to him. He couldn't return to work and it was extremely painful. He was asked not to weight bear, of course, and that then affected his quality of life and activities of living. And we then addressed, well, how can we manage the infection and how can we prevent the infection continuing or increasing in size? So he was discharged home, and again we just looked at a very simple infection pathway and a biofilm pathway combined. We looked at really good cleansing and debridement. We used an antiseptic wash to cleanse the wound with, debridement with the monofilaments, and the patient could do this himself. It didn't require us to do that. Even when we were preparing the dressings, he could do that himself, involving him with his wound care if he so wished to. We used the Cutimed Sorbact, and the patient then with teaching, and his wife was a nurse, did the dressings themselves and attended the clinic on a weekly basis. You can see the drastic, the great improvement, should I say, following reassessments, and it was important that we did those reassessments frequently. The patient, more so than ever, said that the main thing for him was malodor was no longer a problem and the pain wasn't problematical. You can see how quickly the wound improved. Devitalized tissue was removed from the good wound bed preparation, but the use of the antimicrobial dressing, and he had other antimicrobial dressings on, but this really helped to reduce and take away the bacteria into the dressing itself. And the main thing for him, he'd had numerous IV antibiotics whilst in hospital and oral antibiotics prior to being admitted to hospital, and during this episode of care, and the wound went on to completely heal at week 12, there was no antibiotic therapy given. It was just a really good wound bed preparation and antimicrobial, and the big impact to him was his self-care and ability to return to work. So in summary, we know infection occurs, we know it is always going to be problematical in wounds, but it only becomes problematical when the multiplication of the bacteria overwhelms the body's immune system, and then that causes significant deterioration to the wound and can also cause spread and infection systemically to the patient. We know we need to identify wound infection quickly, but we mustn't ignore the fact the presence of biofilms can be overlooked. So if we suspect wound infection or a wound is not healing, just chronicity of a wound is just not healing, it's static, whatever words you want to use, you really have to suspect that that wound has a biofilm, and you need to implement a biofilm-based wound care pathway. And those early diagnosis and management is vital, because as we saw on the infection continuum, as long as those microorganisms continue to increase and in virulence, they will then start to become harmful to the patient themselves. And as clinicians, and patients, we should always be mindful of those signs and symptoms, even the subtle signs and symptoms, and be mindful that in some patients those subtle signs and symptoms may be absent. In particularly those patients with neuropathy or diabetes, they may not have the cardinal signs of erythema and infection. So we have to listen to the patient and address that possible masking. And that, the Cutimed Sorbact has been proven is a safe dressing to actively prevent and manage wound infection, because let's remember it's preventing that infection as well. There's lots of free education and training, and we've only had an hour tonight, unfortunately, to go through a really large topic with you, but a topic that I really think is important. I know we've gone over infection again, but bearing in mind that infection is probably leading from biofilm formation that's not being addressed. There's lots of other modules that you can look at, anatomy and physiology of the skin, lots of things to help assist you with your education, and available by Essity's website. We'll now move on to our real-time question and answer session, and remember you can take part at any time by commenting on the video. Moving on to our first question. The NICE Infection Guidelines 2013 have a quality standard related to teaching patients and carers about looking out for early signs of any impeding infection. I wonder how well that has been implemented. Well, I don't know if that's a question or a comment really. I know very much we did listen and recognise that from those guidelines in 2013, and I know locally in our area, and I know certainly in our new wound healing service, we are teaching, we very much involve patients and carers about looking out for signs of infections. I do agree. I don't know nationally how well that's been implemented. I think it's like maybe a few things in wound care that some areas adopt and some areas don't. They're nice guidelines, so we should be adopting them. But again, I very much feel, if it's not implemented in your areas, then we can challenge that, can't we? We have the evidence there, so the evidence says that we should challenge and be advocates that is introduced into our areas. So I'm not sure if I answered your questions, but it's certainly a very good one for discussion. But certainly, if it's not in your area, do challenge and raise that maybe it should be. Question number 3, if a leg wound is not healing, would you Doppler? I would Doppler a leg wound from day one. I wouldn't wait till it's not healing, because at the end of the day, a wound to the leg or to the foot, you want to know about perfusion. You want to know about arterial supply to that wound. Or even if there isn't a wound, if there's a risk of a wound. So I would do a Doppler, I'd do a vascular assessment from day one if you can. Obviously time permitting, but certainly from first presentation within that week, I would be doing that assessment. Because even if the limb is showing arterial compromise, you need to refer that patient on. You're going to prevent that wound from becoming significantly worse, and you'll be saving potentially the patient's limb. If the wound flow is good, if arterial supply is good, and the patient can have compression, and it's a leg wound, compress it. because I will guarantee with evidence by, even if there's no venous disease, if there's edema around the wound bed, if there's edema within the limb, by compressing, you're going to help to assist to remove the fluid and encourage more oxygen, etc., nutrients to the wound bed. So yeah, definitely, but don't wait till it's not healing. What type of dressing can be used for a wound with high exudate and skin maceration? I would start with looking at why have you got high levels of exudate and skin maceration, and I know that sounds very simple. So the first things I'd be looking at is, let's go back, are the signs and symptoms of infection, because that is an indicator of why there's high exudate and skin maceration. If there was, I'd be starting to think about that wound debridement pathway and antiseptics, etc. So that's my primary, and that's my skin preparation and my wound bed preparation. If there was no clinical signs of infection, why again? Is it high exuding and skin maceration? Is it because of the locality of the wound? So particularly on limbs, if there's edema, if the patient's immobile, if the patient's not as mobile, then again, there could be a problem associated with edema. So again, could I compress that limb? Could I remove some of that edema? And then the exudate levels will decrease. But whilst I'm doing that, you really do need to think about a superabsorbent dressing. Okay, you need to think about something that is going to take away the high levels of exudate into the dressing itself, okay, because some wound absorbent dressings won't do that. Some simple wound absorbent dressings, the exudate may, if it's high levels of exudate I'm talking about now, it will sit within the pad on the wound bed and on the skin. And that's what's causing the maceration, by the way. And then that causes a higher risk of infection and tissue breakdown. So make sure you think about a superabsorbent dressing, because it works on the principle it will absorb the exudate into the wound dressing itself, away from the skin, okay, and away from the wound bed itself. And then it will allow the bacterial burden to reduce because you're taking away the high levels of exudate, and then that should start to improve with the skin maceration. So superabsorbents, and looking at the locality of the wound, do you need compression or elevation, those sorts of factors. What is actually causing the exudate, high levels and skin maceration? And again, if it's infection or biofilms, good pathway there as well. What do you recommend to cleanse wounds with? Oh, I hate getting asked questions like that really, because it's, well, I don't, but if I suspect a biofilm or infection, I will use an antiseptic cleansing agent. So there's various ones out there, and please, I apologise if I don't mention them all, but things like octenoline, Prontastan, they're really good, some good cleansing agents out there. So the antimicrobial properties are in a surfactant or within the solution themselves. If it's generally a healthy looking granulating wound, then I will just use normal saline. But again, check your own local policies, but that's what I would do. But certainly if I suspected biofilms or infection or local infection, then I would use an antimicrobial agent to cleanse. But not just cleansing, think about your debridement method as well, and make sure that you are not just cleansing, you're debriding as well, because of that reformation of that extracellular matrix. So we need to break it down in order for that cleansing agent to be effective. So final question, what are your thoughts on long-term prophylactic antibiotics? Oh, this is a hard one. For a large, initially infected pressure sore. What I will say, right, I have to break this down a little bit. So it's a large infected pressure sore, initially had antibiotics, and I understand that if the patient was acutely unwell and if it's a very large, deep, and I'm assuming it's a deep infected pressure sore. Prophylactically, I wouldn't, if I'm being honest. I would look at the really continual cycle of antiseptics, antimicrobials, having breaks if the wound looks healthy and it's improving. The only thing there though is if that pressure ulcer is down to bone, underlying bone, etc., could there potentially be any infection in the bone? I don't know, I can't answer that, but that's what I would be thinking. But routinely, no, I wouldn't. I would only, and that wouldn't be my decision either, I would be working with, the surgeons or the orthopedics or the microbiologist to say, do we treat prophylactically? But routinely, no, not at all. And I wouldn't make that decision either. So if somebody is being nursed prophylactically long term, do go back and question why. Think about the resistance there. So that was the final question. Thank you very much. Some very, very good questions there as well. So I thank you for taking the time and effort to send those in. It concludes our seminar for this evening. I'd like to thank this opportunity to thank Essity for their support of this event. And I'm sorry, my mouth was very dry tonight, so if some of my words have not been quite as clear, I do apologise. If you're interested in trying the Sorbact technology, like a free wound assessment guide, then get in touch with Essity. Contact details are on the screen. Thank you for watching, and good night.